So a brief introduction to Parambir, to Dr. Dulai, who I think we've been quite fortunate in British Columbia that maybe because he's on the West Coast, and even if he were to leave the West Coast, he hopefully will also still have some attachment to Vancouver. I think he has some family attachment here, that he has spent time with us over these last few years, teaching us a lot about a new way to think about how we can assess inflammatory bowel disease. He is certainly, I don't even want to call him a rising star, because he is a star in every sense of the word when it comes to moving our field forward, thinking about in an innovative way how we can better assess our patients and then ultimately treat them. So we are honored to have you, Parambir, to talk with us, spend time with us tonight. And this is a particular area of research that he has focused in of late, which is understanding what would be perhaps some fairly simple, perhaps clinical decision tools that we can use in our daily practice to optimize patients with inflammatory bowel disease.
Yeah, thank you so much for that thoughtful introduction and for having me here today. And I'm going to try my best to follow on Remo and Peter here. And hopefully people feel like we did a decent job with this discussion for decision support tools in IBD and treatment selection. So what I want to talk to you today about is three big concepts that you should think about when you're trying to both apply decision support tools and understand how to individualize treatment decisions. The risks of under or over treating inflammatory bowel disease. How do you individualize prognosis? And how do you select treatments with some of these tools? So when we think about under and over treating a patient, the source of the risk is the same. It's a lack of an ability to prognosticate risk of disease complication, disease progression despite therapy, and prediction of treatment efficacy. What are the risks to the patient? So if you undertreat them, you're allowing them to progress to complication, but there is also risk with overtreating. Not all patients are actually at risk for disease complications, and therefore you unnecessarily expose them to an intervention. And not all patients need treatment escalation, combination therapy, dose optimization. What's the risk to the treatment? So you have limited effectiveness of drugs when you use them after complications have already developed. And for overtreating scenarios, you may over or underdose treatments. You may cause immunization of the biologic, or you may tarnish the safety profile in somebody who didn't otherwise need it. The risk to the payer is cost on both spectrums, but it's costs from complications and undertreating and costs related to treatment for overtreating. And the risk to the healthcare system is resource utilization in the form of hospitalizations, ERs, and surgeries for undertreating, but colonoscopies, infusion centers, clinic visits, and some of the costs related to overtreating in the healthcare system. So one of the first things you want to do and think about is individualizing prognosis to slow the progression of the disease. And you want to think about three key domains: disease prognosis. What's the risk of a disease-related complication at baseline for an individual patient? Treatment prediction. What's the probability of them responding to a specific drug if you were to start it? And what's the treatment prognosis? The risk of a complication despite being on a treatment. There are three different scenarios, but what they help you answer is: who needs a biologic? What biologic should you use? And how do you optimize that biologic once you started it to continue to reduce that risk of a complication? So this is the AGA clinical decision support tool that was built in 2014, and it's available online for ulcerative colitis and Crohn's disease. And it's based on the premise that early identification of moderate to high risk patients being moderate to high risk for complications is crucial for early initiation of treatment to prevent disease progression. It's easy to interpret clinical factors, and they have an algorithm online for rapid review. And as you can see on the right here, it's very simple things like age, disease extent, perianal disease, severity or severe rectal disease, and depth of ulceration, but it might be too late. Some of these patients have previous surgical resection, stricturing behavior, penetrating behavior, which are prognostic of progression to future complications. The AGA had created a decision support tool where it was pretty easy to follow. On the left here, you can see the clinical decision support tool itself. It's very simple. You assess the current burden. They're either low or high risk for a complication. If they're high risk, then you start a therapy. If they're low risk, then you start a lower risk or sort of more appropriate therapy. And then you continually assess them for remission versus continued disease. And when thinking about, at the time of making this, when thinking about low risk or high risk, you're talking about steroids or immunosuppressive agents. And for more moderate to high risk patients, you're talking about anti-TNF therapy, combination therapy. But again, therapies have evolved over the last 6 years since this initial tool was developed. And the Care Navigator also allows for you to say, okay, well, you reassess them, you switch to a different therapy, you try to optimize, but it provides little guidance on what to expect and whether optimization is in the form of drug monitoring, treat to target, or when you should consider abandoning therapy because they're expected to have adequate concentrations. So sort of decoupling the concepts of disease prognosis and treatment prediction, there's a new tool that's now available called CDPATH, which allows for clinical risk stratification for Crohn's disease complications. And this tool was developed with 5 simple steps. So the goal was to identify risk factors for progression to a complication in the first 3 years of the diagnosis. Then to define the population that would most benefit it, which was sort of before a complication developed it, validate it in other populations. And for this study, they did both adult and pediatric, develop a simple, easy to use decision support tool that could engage in the shared decision-making process, and then disseminate it in practice for use. So the original model that was built on about almost 700 patients looked at time to complication of Crohn's disease within the first 3 years of diagnosis. And this had simple factors, clinical factors like small bowel location, colonic location, perianal disease, but it also had biomarker and genetic factors like ASCA, CBER, and NOD2 mutations. And on the right here, you can see the concordance calibration, which is an area under the curve for time to event analyses. And the original cohort, the area under the curve or cohort calibration was 73%. And you can see in the secondary adult validation cohort and in the pediatric validation cohort, it was 73 to 75%. So this was prognostic of risk of complication, and it was valid across multiple populations for predicting this. But this is not an easy to use model or tool that you could actually apply in practice, trying to get these lab values and deciphering how to put these together to make a decision. So what the authors wanted to do, and I was fortunate enough to sort of be involved in this when I was at Dartmouth with Corey, was they used system dynamics analysis to try to communicate that complex data in a simple fashion to a patient for their individual prognosis. So system dynamics is a method that addresses inherent dynamic complexity of interaction between variables, and it provides real-time individualized predictions of outcomes. It has simple inputs. You have a little control panel that you just sort of toggle back and forth, and it graphically conveys the outcomes over time, and you can add new data to an existing model. This was actually sort of around the framework of weather mapping. So complex interactions of wind pressures, geometric pressures, sort of height, all these different things, and trying to easily predict whether it's going to rain or not, whether it's going to snow or not, and showing that in a graphic format to the user. And so really just taking complex clinical data, but now thinking about this and applying it in patient-friendly results. So this is an example of what the CDPATH tool looks like. You have on your far left here the example of low-risk patient. So it tells them that they have a less than 20% chance of a disease-related complication the first 3 years of diagnosis. The middle one is that it'll tell them that they're medium risk between 20 to 60%. And the last one is a high risk, 60 to 100%. So this, I think, really helps guide decisions around who needs combination therapy, starting a biologic, or even helping the patient understand that although they may feel well because the symptoms don't correlate with their endoscopic activity, that their disease is actually very high risk for progression, and we need to start something now to prevent that complication. There was a validation study done, and you can see those results here on the left, with absence of complication being teal and development of complication being in red. And you can see the low risk patients of these 106 had none of them develop complications. The medium risk about 28%, and the high risk about 58%. This is actually commercially available now for use, at least in the US. And you can order this in clinic and get it back within about a week to actually show patients what these outputs look like. So when you think about it, whether it's the AGA risk of complication prognostic decision support tool, or whether it's the CDPATH, the goal then is to take high-risk patients and start them on a biologic with proven ability to reduce disease-related complications. For the most part, that's going to probably be anti-TNF therapy based on prior literature, but they may have already failed that, or they're unable to take it for a variety of reasons. And in that situation, you do need some degree of treatment prognosis and prediction. And for patients who are low risk, but still need to start a biologic for repeated courses of steroids, or what appears to be potentially more severe disease, but doesn't fit the high risk categorization, you have some opportunity to personalize therapy with monotherapy agents or other agents that are now available. So when you think about treatment prediction, there's really three concepts, and Remo touched upon some of these earlier as ways to optimize therapy. There's effectiveness, or the risk of adverse events, where you can think about, and rapidity of onset, and you can think about co-induction here with steroids or even a second biologic, as some have alluded to earlier. There's drug exposure, which you can think about with dose optimization and therapeutic drug monitoring. And then there's treat to target monitoring, which is an evolving concept, both with biomarker and endoscopy-based treat to target monitoring. But the core around this is the ability to identify patients who are at risk for either lack of efficacy or who are likely to develop efficacy despite the need for any of these co-interventions. So a few years ago, we developed some clinical decision support tools around this for vedolizumab, ustekinumab, and other biologics that were coming to market. So what we did was we took the pivotal phase 3 clinical trial programs for both Crohn's disease and ulcerative colitis, and what we're showing here first is Crohn's. And we built a clinical prediction tool and decision support tool that we then validated in a large collaborative consortium across the US of over 20 academic centers. This tool was meant to guide the selection of optimal treatments for patients and help guide whether a patient was likely to respond and how quickly they were going to respond potentially. And you can see here the abstract from our paper on this from a few years ago. We looked at steroid-free remission, clinical remission, and durable remission. You can see the predictors are quite simple: bowel surgery, prior anti-TNF exposure, prior fistulizing disease, albumin, and CRP. Some may argue that those are common predictors to all drugs, but I'll show you some data later that the way we weight these for each drug actually allows for drug-specific prediction. And so you stratify a patient as having either a low or high probability of response based on a simple calculation or calculator. These are the results from the Victory Consortium validation, where we looked both at clinical and steroid remission, but also mucosal healing. And you can see the low probability group in orange. Very few of them actually achieved these outcomes out to week 26. But those who had intermediate or high probability, the rates of clinical remission, mucosal healing, and deep remission were significantly higher in the patients who were intermediate or high probability compared to the low probability. You see a nice linear trend in efficacy or effectiveness, since this is observational data. We then took this a little bit further and said, well, can this tool predict rapidity of onset? At the time of doing this analysis, there was a lot of talk about how vedolizumab was slow onset in Crohn's disease. And what you can see here is the low probability group in orange indeed had a very slow reduction in their Harvey-Bradshaw index from baseline, whereas the intermediate probability had an incremental rapidity in onset of the drug, and the green probability, or the high probability group, actually had a quite rapid reduction in the Harvey-Bradshaw index over the first 10 to 14 weeks, and this continued out to week 52, suggesting that the rapidity of onset was really tracking along with just their overall probability of responding to the drug. Along that spectrum, we thought, well, maybe therapeutic drug monitor, therapeutic concentrations and drug concentrations also tracked with their probability of response. And we saw the same. So you can see here, these are measured concentrations of vedolizumab over week 52, stratified by their baseline probability of response to the drug. And the orange graph is the patients who at baseline had a low probability of response to vedolizumab in Crohn's. And then you can see this stacking effect, where the higher the probability, the higher the concentration of the drug observed over 52 weeks. What was really notable for us was that this incremental observation for concentrations was seen at every point in assessment. This is post-dose, so immediately within 2 hours of the dose, to trough concentrations to mid-interval concentrations. There was really no overlap in these concentrations over the 52 weeks. So, that showed us that the probability of response or decision support tools predicted efficacy, rapidity of onset, and therapeutic or sort of drug concentrations to guide therapeutic drug monitoring, treat to target strategies, and some of these other concepts. But we also wanted to look at disease modification and risks for complications. So this was a post-hoc analysis that we did of the Gemini data, both the phase 3 data and the long-term safety data over 7 years, where we combined both the decision support tool and early disease intervention, or sort of patients who had a diagnosis of less than 2 years, less than 3 years, or less than 5 years, with the thought that the decision support tool might be most effective in identifying patients who are at risk for complication or response to therapy and future complication stratified by disease duration. So on the left here, you can see that patients who are predicted to have a low to intermediate probability response, if you intervene early in their disease, you were able to overcome that probability somewhat and have a lower rate of complication over 7 years than if you had intervened later in their disease. Whereas patients on the right who have a high baseline probability of response to vedolizumab, their overall surgery rates were actually lower no matter what. And it didn't matter whether you intervened in the first 2, 3, or 5 years of their diagnosis. The rates were quite comparable, irrespective of when you intervened. And therefore, they were high probability regardless of what spectrum or duration of their disease they were in. So that was sort of interesting to us to see this stacking effect where you combine a decision support tool with another variable that was available in practice. We then switched gears to ulcerative colitis, a similar pathway. We took the phase 3 data, built a model. The prediction tool identified disease duration, anti-TNF exposure, moderate endoscopic activity, and baseline albumin, built a calculating tool that you can then calculate and stratify into low, intermediate, or high probability response to vedolizumab. What we did differently here is we tried to validate the tool on vedolizumab treated patients and anti-TNF treated patients to assess whether it was specific to vedolizumab. So on the left-hand side here, you can see for the outcome of corticosteroid-free clinical and endoscopic remission at week 26, patients who were deemed to have a low probability of vedolizumab with a solid orange bar had lower rates of this outcome compared to a patient who was low probability but started anti-TNF therapy in the dashed orange bars. When you get to the intermediate probability group, those who were intermediate and started on vedolizumab, the solid orange bar, were comparable to those who were intermediate and started on an anti-TNF agent. Whereas when you got to the high probability group, those who were high probability of response to vedolizumab and started on vedolizumab had higher rates of corticosteroid-free clinical and endoscopic remission compared to those predicted to be high probability response to vedolizumab but started on an anti-TNF agent. So this helped demonstrate some potential drug specificity in this initial validation. Similar to what we did in Crohn's disease, we looked at rapidity of onset. And so this is reduction in partial Mayo score. And so similar to Crohn's, the orange or low probability group had slower improvements in disease activity over 52 weeks. And the intermediate and high probability had more rapid reduction in disease activity scores. And similar to Crohn's, you saw this stacking effect for measured drug concentrations over 52 weeks between the low probability in the orange, intermediate in yellow, and high probability in green. Now, we wanted to take this one step further, and so recently we actually validated this in Varsity. So Varsity is the head-to-head trial of vedolizumab versus adalimumab, and we were able to demonstrate that the tool does predict measured vedolizumab drug exposure concentrations. So here the teal bar is the high probability, black is intermediate, and red is the low probability, very significant differences throughout the 52 weeks of the study. But what Varsity afforded us was a very clear opportunity to prove whether this tool was specific to vedolizumab or whether it predicted outcomes for adalimumab as well. And so this is the area under the curve for the comparison of vedolizumab versus adalimumab. So baseline probability of response using the vedolizumab decision support tool for predicting histologic and endoscopic mucosal improvement at week 52 with blinded central readers was 71% for those who got treated with vedolizumab in this randomized controlled trial, versus 54% in those who got treated with adalimumab in this randomized controlled trial, suggesting that this tool was indeed specific to predicting outcomes for vedolizumab and ulcerative colitis. Now, how do you personalize this then in clinical practice? So when you stratify the clinical trial by their baseline probability of vedolizumab, and you look at clinical remission, which is bar A, It was the high probability group where you saw in the blue bars a significantly higher rate of clinical remission with vedolizumab versus adalimumab, whereas in the intermediate probability, they were comparable, and in the low probability response to vedolizumab, adalimumab actually looked like it might have been favored. Similarly, for week 52 histologic remission and endoscopic remission, you saw that it was the high probability of group where vedolizumab was favored significantly over adalimumab, and not so the case in the intermediate or low probability group. So suggesting that this tool could actually be used to personalize evidence from a phase 3 head-to-head randomized controlled trial. We also did this for ustekinumab and Crohn's disease, and so this is the tool that was built there. So this similar probability of response based on simple variables, anti-TNF exposure, bowel surgery, fistulizing disease, smoking status, and albumin. But if you go through the literature, and I'm happy to share this with anybody who'd like it, the weighting is different. Anti-TNF exposure was more prognostic in the vedolizumab model than it was in the ustekinumab model. Smoking history was not present in the vedolizumab model, but it is present here, and the albumin scoring and weighting is different between the two. And so similar to what we saw with vedolizumab, for the ustekinumab model, it is actually able to predict separation and clinical efficacy over the first 16 weeks, with the high probability group being the green bar, intermediate being the blue bar, and the low probability being the red bar. And I don't have the data here, but we are doing some validation work, which is showing that the ustekinumab Crohn's disease model does not predict outcomes for vedolizumab, but it does for ustekinumab. And the vedolizumab Crohn's disease model does not predict outcomes for ustekinumab, but it does for vedolizumab in Crohn's disease. So these tools are all actually available now online. This has recently been endorsed by the AGA. And so it takes you through a simple yes/no toggle for telling you whether a patient is high risk for a disease complication. And then you can actually input the different variables that go into all of the models in a simple user format. And what you get is a prediction for vedolizumab, ustekinumab, and infliximab in Crohn's disease with a probability of response, low, intermediate, or high, how quickly you should expect a response within 4 to 6 weeks, 2 to 3 months, or 4 to 6 months, and whether they should get more frequent treat-to-target monitoring or drug concentration monitoring because they're expected to have low, adequate, or high concentrations. We have some user data around this. This launched about a year ago. There have been nearly 3,000 sessions started in the top left here, the educational reach. And surprisingly, a good proportion of these were actually primary care providers or mid-level providers. Practice change, about 75% indicated that they had an increase in knowledge and 45% anticipated an improvement in patient outcomes. What was quite striking was the gains in knowledge confidence. So knowledge confidence is getting the answer right and knowing you got it right. And so we saw an increase in the relative change of knowledge or correctly answering the question. But what was surprising, we saw a 200% increase in mastery, meaning people picked the right answer and they knew they picked the right answer and felt confident in the answer they made. And of the over 4,000 actions taken, the clinical decision support tool was the #1 downloaded resource. And this is available for free for anybody in the world. And you do get CME credit for this when you use this. So just to sort of summarize here, individualized prognosis and treatment selection is indeed possible with these decision support tools, and you should think about stacking them together to provide a full view for the patient. Practice-based learning through the US IBD Health Outcomes Consortium CME activity has actually improved outcomes in practice and learner knowledge. And further optimization and integration is undergoing with some of the newer therapies that are becoming available and some additional ways to optimize the interface for these. So I appreciate the opportunity to present here. I'd be happy to take any questions that you might have.
Thank you, Parambir. That was fantastic. One thing I'll ask you to do maybe during the panel discussion, do you mind putting the link of that website maybe in the chat so everyone, yep, that would be helpful. I would imagine you're using it regularly in your clinical practice.
Yes, very much so.
So with some of the points that Remo suggested, that there's obviously tremendous value in a patient understanding efficacy signals. There are other mitigating circumstances that very much could influence the right choice of the right biologic. How has this tool been integrated into your practice, and do you see it being the dominant reason why someone picks a strategy more so than before you have the tool?
Yeah, so there's a few ways that I've personally integrated and a few ways that I've heard of people integrating it. So the few ways that I've integrated it is to help both the patient understand what their probability of response is, because some patients come in, really just like, hey, look, I saw that commercial. This is the drug I want. It seems really safe. But when you show them what their probability of response is, whether they're likely to respond to it or not, it opens up the conversation a little bit and breaks down that barrier to some extent. The other way that I've seen it used is that some people will use it after they've already started a therapy for people who are failing a drug. So if you're failing vedolizumab and you were a high probability of response to that at baseline, odds are you're not failing because your drug levels are low or because you're not achieving saturation, because we've shown that the tool predicts drug concentrations. And so they'll actually, not dose escalate or waste a bunch of time on it. They'll potentially move on. But if they see that they were maybe somewhere in the intermediate or low probability range, they'll spend some time trying to optimize the drug before they think about abandoning it. And then the other part that I've seen some people use it is to sort of get a flavor of whether their own decision making was something that they felt sort of was appropriate and fit with some of the literature and evidence that goes around it. So those are the three ways. I don't see this being the only way to choose a therapy. I don't think we'd ever get to a point where we can tell somebody what they absolutely need to take. I think we can guide them on what they're most likely to benefit from. And then you still have to have some personalization when you're having these conversations, but the visual way that these are displayed, I think, allows for that in an easy to use format.
That's excellent. A couple of questions have come in. So the first one is, how well does CDPATH work for patients who've had disease longer than 3 years? Is the output still applicable, given that there would be more years of data not included in the calculation?
Yeah, that's a great question. It has not been validated for patients who have had a diagnosis of greater than 3 years or those with prior complications. So I think in the current format, its validity is really limited to the first 3 years of the diagnosis. But as I mentioned, the system dynamics model allows you to update this as more data comes in. So I think as Corey and Marla and others in that group get more data on its performance or other factors that might modify the model, and those with prior complications or those with 5 to 7 years, they can probably update the tool as pretty easily for broader dissemination and sort of validation.
Okay. And then another question, the CDST is fantastic. I've used it regularly. Do you think it's reasonable for patients to look or use it? So is it something that perhaps it should be in the hands of patients to give them more confidence in the decisions that are being made?
Yeah, I don't see a reason why not. I mean, we had geared it towards providers, but there's no reason why patients can't access it. It's a freely accessible website. So anybody can really log on and take a look. You don't have to have an NPI number or log in with specific credentials to be able to see it. So, and for people who want to be well informed, we have references to all the papers, and they may want to pull up the papers and sort of get a sense of what went into this and take a look under the hood. So yeah, I think for the patients who are really engaged, why not give them the link and let them play around with it?
Okay. Is there an app that's coming, or?
So that link that I just sent can be pulled up on your phone or a computer. We're working on actually integrating it into the EMR. So we've been talking to Cerner and a few EMR companies about just having it auto integrated, where your note might be able to just pull up all the scores automatically for you, because we're sort of functioning on the provider side of things. So I think that was the next step. And then, alongside that is working on creating just sort of an app that can go on your smartphone for ease of use.
Okay.
With my face right in the middle of it.
Absolutely. And then how about for ulcerative colitis? Is there something, are you working on something like this for ulcerative colitis, or?
Yeah, so the tool, I just showed the Crohn side of it, but it has a UC side of it to it as well. We need to update the UC side with ustekinumab and ulcerative colitis once we get access to that data. But, I think the UC side of it's there as well for people to use.
My question for you is, so you've been through this, you're using it regularly. What's the shortcoming besides the longer disease duration?
Yeah, I think one of the shortcomings is it's hard to really, the populations where it's difficult to really get much out of it is when you have somebody who's sort of high probability for multiple drugs or low probability for multiple drugs. And that's where we are working to hopefully refine the tools where you can say they're really high probability versus just high. And I think that's where one of the shortcomings is. If somebody's high probability for 2 drugs, then it doesn't really give you too much more to go off of, and you have to talk through it a little bit. Or if they're low probability for everything, you don't really have any guidance on what you need to do next there.
I don't know if you have this issue in the US. I imagine it's very different. In Canada, one of our main limitations is payer and what's covered, right? So we often, that actually really refines it down to kind of one or the other choices. We very seldomly do we really have the full menu, so to speak. I don't know if that's a factor in this or not.
Yeah, so that was an issue. That is an issue for us in the US, especially as the drugs are initially coming to market. And several of the sort of folks at some of the other sites for the consortium actually said they used the tool to successfully argue with a payer that the payer would actually benefit in the long run if they gave them the drug now. And so I didn't expect them to start taking the manuscript or the tools and start going to payers, but that is an angle we're hoping we can get into, is actually just telling payers, hey, look, overall bang for your buck, you're going to save a lot of money from complications if you allow for these tools to be used, even though the drug seems more expensive. And talking to some payers, that's what they've been looking for. They don't want to allow, the most expensive drug to be used for everybody first line. But if you can tell them that this one patient really, really would benefit from it, I think they would probably see the value in it.
So with regards to Remo is asking, how often do the probabilities overlap for the different drugs?
Yeah, so when we looked at this in the sort of 6,000 Crohn's patients that we had in the consortium, it was about 35% of them that could not be clearly separated out into one drug that was superior. So 65% we can say with confidence, there's one drug that's like top of the line, but in 35%, there's just too much overlap to be able to do that. And that 35% is where we're focusing on some additional machine learning modeling to try to see if we can optimize the prediction.
Excellent. Thank you, Parambir. That was fantastic.